Hi, my name is Alyssa Mustacchia. I am a speech-language pathologist, and today I will be discussing cranial nerve number 9, namely the glossopharyngeal nerve, and running a cranial nerve examination on this nerve. So the glossopharyngeal nerve is a paired sensory and motor nerve, and it originates at the medulla oblongata and terminates at the pharynx. More specifically, it derives from the third pharyngeal arch and is actually the only structure to do so. It exits the skull through the juguli or foramen, goes next to the superior and inferior ganglia that house the cell bodies of the sensory fibers. Next, it descends the neck, providing information to the stylopharyngeus muscle of the pharynx and sensation to the carotid body and sinus, which is where it exits the pharynx and splits into the pharyngeal, tonsillar, and lingual branches, which we'll get into a little bit later on. So the glossopharyngeal nerve has a bilateral innervation. This just means that it receives impulses from both the right and left hemispheres of the brain. It also carries both afferent and efferent information, which means it carries information both to and from the brain. Its branches of nerves include tympanic, stylopharyngeal, carotid sinus, pharyngeal, tonsillar, lingual, and a communicating branch to the vagus nerve or cranial nerve number 10. Cranial nerves 9 and 10 are very close to each other, therefore they are very interconnected. In fact, cranial nerve examinations on these nerves are often done together instead of separately. The tympanic nerve, also known as the nerve of Jacobson, carries parasympathetic fibers and eventually exits the skull via the foramen ovale and its synapses at the otic ganglion. The stylopharyngeal nerve provides motor innervation to the stylopharyngeus muscle. The carotid sinus nerve communicates with the vagus nerve in order to carry signals from the chemoreceptors in the carotid body and the baroreceptors in the carotid sinus, which helps monitor blood oxygen and carbon dioxide levels as well as regulate blood pressure levels in the body. The pharyngeal branches of the glossopharyngeal nerve join with the pharyngeal branches of the vagus nerve and sympathetic nerves in order to form the pharyngeal plexus, and what this does is it innervates the muscles of the pharynx. The tonsillar branches provide sensory innervation to the palatine tonsil. The lingual branches supply the vitae papillae, mucous membrane, and follicular glands to the posterior third of the tongue. Its efferent or motor aspect supplies motor innervation to the stylopharyngeus muscle of the pharynx. This muscle is important for elevating and widening the pharynx and larynx, which is especially important during speech and swallowing. The efferent fibers also provide information to the carotid glands, which originate in the inferior salivary nucleus, travel with the tympanic nerve through the foramen ovale, and synapse at the otic ganglion. Its afferent or sensory aspect carries sensory information from the carotid body and sinus. It provides sensory innervation to the upper pharynx, oropharynx, external ear, middle ear, eustachian tube, and posterior third of the tongue. It also carries taste, sensation, and information of the posterior third of the tongue. So I will now be conducting an examination on cranial nerve 9 on my client Rosanna. It is important to note that testing cranial nerve 9 in isolation is very uncommon and impractical since it is so interconnected with cranial nerve 10. So Rosanna, can you please give me your full name and date of birth?
Rosanna Mustacchia, November 3rd, 1965.
Okay, great, thank you. So there, Rosanna did not display any hoarseness, whispering, slurring, or nasality, which are things that cranial nerve 9 impairment can result in with regard to phonation. Okay, Rosanna, are you ready to get started?
Yes.
Okay. I will begin by testing your swallow. Can you please take a sip of this water? Great, how did that feel?
Good.
All right, good. So she showed no choking or difficulty swallowing, which implies that her pharynx and larynx are elevating the way that they are supposed to. I will now be using a cotton Q-tip to place in the back portion of your tongue. I want you to tell me if you taste anything salty, sweet, or bitter.
Okay.
Okay.
Sweet.
Good. It was sweet. So if the glossopharyngeal nerve was impaired, Rosanna might have difficulty tasting in the back portion of her tongue. Now, I would like to use this tongue depressor and pen light to look in the back of your mouth. Can you please say ah for me? Okay, great. So the uvula remained in the middle as it elevated, which demonstrates symmetrical elevation. I will now be touching the posterior or back portion of your tongue with the tongue depressor to check your gag reflex. Is that okay?
Yes.
Okay. Okay, good. The sides of her palate elevated symmetrically. However, it is important to note that bilateral absence of gag reflex is normal. This test is to ensure that at least one side is intact, which in this case both were. If there was a problem with the gag reflex, it may lead to choking. When I had my client open her mouth and say ah, both sides of her palate elevated symmetrically. This is important because if there was a bilateral weakness or total weakness, nasal air might escape and cause phonation of oral sounds to sound nasal because the soft palate would not completely close off the nasopharynx from the oropharynx. Okay, great. Thank you for helping me.
Thank you.
So we already know that the glossopharyngeal nerve is obviously important for speech and swallowing as it elevates and widens the pharynx and larynx. Therefore, damage to the glossopharyngeal nerve can result in a number of different deficits. Glossopharyngeal nerve palsy may result from a few different injuries, including syndromes that develop post-stroke, such as Burnett syndrome, Collett-Sickard syndrome, and Villeret syndrome. Dysphagia, or difficulty swallowing, is another common effect of damage to the glossopharyngeal nerve, which may result from a stroke, head injury, dementia, oral cancer, gastroesophageal reflux disease, or even a developmental disability. Some people with dysphagia cannot swallow at all, while others may have trouble with only some foods and liquids, which is why some people with dysphagia are prescribed a thickening powder to put in their liquids by an SLP, and this allows them to swallow more easily. Dysphagia can also co-occur with coughing or choking when eating or drinking. A speech-language pathologist is important during the treatment of dysphagia because they are the people who assess a patient's swallowing and give them dietary restrictions to follow, as well as develop treatment plans in order to improve safety with swallowing and reduce caregiver burden. Impaired taste and reduced sensation to the posterior third of the tongue, palate, and pharynx are also effects of impairment to this nerve. Reduced sensation is important with regard to swallowing as well, because the SLP may have to put the client on a dietary restriction in order to reduce choking. There may also be a buildup of bolus if the client cannot feel part of their tongue, as well as a loss of carotid sinus reflex, absent gag reflex, as well as parotid gland secretory dysfunction. Gag reflex is so important with swallowing with two because it needs to be intact in order to prevent choking. Some of the conditions that can cause these problems are a styloid fracture, Eagle syndrome, glossopharyngeal neuralgia, and a tonsillar carcinoma. One that I would like to discuss today is Eagle syndrome, which is often a result of throat trauma or tonsillectomy, and it presents as a persistent throat pain that may radiate to the ear and worsen with head rotation. This often results in pain when swallowing and altered speech, which are obviously two things that speech-language pathologists must treat. Glossopharyngeal neuralgia is characterized by oropharyngeal pain triggered by swallowing, chewing, coughing, and yawning. Classical glossopharyngeal neuralgia involves episodic pain, while symptomatic glossopharyngeal neuralgia involves constant pain. An SLP is often on the team to provide an evaluation in order to assess what kind of diet is appropriate for clients with this condition. Oral motor and cranial nerve exams and bedside evaluations done by SLPs are important when delving into a diagnosis and treatment of a person with a swallowing problem, often including damage to the glossopharyngeal nerve or cranial nerve number 9.